rheumatologist at Apollo Hospital, Chennai, kindly agreed to talk on the biologics, which is the most advanced therapy in many of the inflammatory diseases, inflammatory connective tissue disorders. He had his DM from Chennai, and he has been a teaching faculty in Madras Medical College and Stanley, and now practices after taking a VRS at Meenakshi Medical College and his own private hospitals called Mallar Hospitals. Dr. Krishnamurthy, please.
Respected Chairperson, dear colleagues and delegates. At the outset, I would like to thank Professor Chandrasekhara, who has organized a beautiful CME today. And the topic given to me is on biological agents in the practice of rheumatology. So let us see what we mean by biologics, what are the drugs that are available, and how they can be used in the various rheumatological disorders. Next slide, please. If you see the word biologicals, why did they coin such a word? Because normally the drugs that we use in rheumatology, particularly in rheumatoid arthritis, or the future will be on line of biological therapy. Nowadays you see people using right and left disease-modifying drugs, maybe thanks to the awareness of the usage of disease-modifying drugs, as well as how pharmaceutical industry has promoted disease-modifying drugs to general practitioners, physicians, orthopedicians, like that. It has got its own advantages and disadvantages. But until as of now, biological agents are still in the purview of the specialists. So I thought we'll use this forum to open up what we mean by biological agents and what are the agents that are available to us in India and how they can be used. So we'll take first the model of rheumatoid arthritis to understand these biological agents, and then from there we'll go to the other disorders in which these can be used. If you know that cytokines, I used the word cytokines or chemokines, these are nothing but small protein molecules or peptides which are secreted by cells. They are released in the local milieu at the site of damage or inflammation. And these are nothing but chemokines or cytokines are normally present in our system. These are signaling methods or mechanisms. How do cell-to-cell interact? Just like mobile phones, which receive signals wherever you are. Cell-to-cell, number of these sort of cytokines are released, and they only cause the signaling. Normally cells have both intracellular signaling as well as intercellular signaling, and chemokines are mainly which can attract other cells, or it can act on the same cell itself, and they have receptors. So biological agents are targeted against these cytokines. Thereby they try to bring about a reduction in immunoinflammation. If you take this slide, for example, I've shown a rheumatoid joint. All of us know in a macroscopic level in a rheumatoid joint there is synovial hypertrophy, a pannus formation, erosion, and damage to the joint. But if you go at the microcellular level or at a microscopic level, the main culprits are three cells. The macrophages or dendritic cells, or these are cells which present antigens. We don't know what antigen triggers an immune reaction in rheumatoid arthritis, or for the example, other connective tissue disorders also. For example, on spondyloarthropathy, we don't know why people develop axial skeletal involvement, why there is bone formation, what triggers them, in what way HLA-B27 or a genetically prone individual gets triggered for development of a disease. So until that is known, we will not have a direct curative treatment. Hence, we are going a little in a circumventing method. At least try to target the cytokines which are secreted, or try to prevent cell-to-cell interaction, thereby try to arrest an immunoinflammation in a joint, and thereby spare the joint and spare the disease for the hapless victim. So the three cells which we can look here are the antigen-presenting cells or macrophages, for example, the T cells and the B cells. And these cells, when they interact with each other after an inciting event, say for example some antigen which is taken by the macrophage, it is processed by it, and then it is presented to a T cell, and the T cell and the macrophage or the antigen presenting cell interact. They release a lot of chemicals or chemokines or cytokines, and that in fact triggers B cells, and that in fact releases antibodies. This is how the whole thing goes on, as a cascading effect. So the biological agents are based on these principles. Suppose we try to prevent the antigen processing cell processing an antigen, or we prevent a T cell interacting with an antigen presenting cell, or we prevent a B cell to produce antibodies. You all know that in the rheumatoid factor, which is a simple test done to diagnose rheumatoid arthritis, is nothing but an antibody produced by B cells, more so at the synovium. How do these cells home into a rheumatoid joint? What attracts them? All these things are based on cytokines. Hence, with one single slide we can work on that. So if you have targets or drugs to act on the T cells, or you target the B cells or their products, then we can bring about a remission. So in the next few slides, I'll just again reiterate the same points for easy understanding. Next slide. This is the events. So the number of cellular events that can occur at a joint, which ultimately result in an erosion of the bone. Here you have the B cells, the T cells, the antigen presenting cells, and how they can interact with each other, resulting in stimulation of an osteoclast, which can cause bone resorption and damage, fibroblasts, and how they can release various chemicals so that, cytokines that, which ultimately result in angiogenesis, then cells secreting cytokines which attract other cells from the vascular area to migrate into them, resulting in inducing adhesion molecules like that. A cell influx occurs into the damaged joint or an inflamed joint. For that, we need so many number of cells and their interaction. Next slide. And the same slide again. You can see the dendritic cells, the B cells, macrophages, like that. It's a conglomeration of different cells. Next slide. And the whole thing can be explained again here. This is only to just reinforce these three cells, mainly the T cells, the B cells, and the macrophages. So when an antigen is processed by the macrophage and they are presented to a T cell, there is a lot of release of interleukin-1 and tumor necrosis factor and other pro-inflammatory interleukins called interleukin-6, interleukin-8, like that. And they also can stimulate a B cell, resulting in and autoantibody formation, or in the case of rheumatoid arthritis, a rheumatoid factor. So suppose we have agents which can prevent this interleukin-1 or which can block this TNF, particularly TNF-alpha, then we can cut off this cascading effect and thereby bring about a remission in this disease process. Likewise, if you prevent a B-cell stimulation, you can prevent antibody formation or rheumatoid factor formation. So we can get drugs for that. Still, next slide. One more step to make it more easier. Here you see a cell, this is T cell, which is interacting with an APC or an antigen presenting cell. These cells, just like that, they don't interact. They need certain receptors. And they are called the T cell receptor. And the antigen presenting cell can present a processed antigen only with the help of a class 2 molecules, which are HLA molecules. And apart from that, they also have parallel structures called co-stimulatory molecules. So nowadays, agents are targeted against these components as well as, which are in turn, it means that it is against the T cell. So agents which prevent an interaction, these co-stimulatory molecules between a T cell and an antigen presenting cell, are ultimately aimed at targeting the T cell. So any interaction between a T cell and an antigen presenting cell results in the production of the following cytokines like TNF-alpha and interleukin-1 and interleukin-2, like that. The important things are the IL-6, IL-1 and TNF-alpha, which cause severe inflammation. Just like the way that there are pro-inflammatory cytokines, there are also anti-inflammatory cytokines. Particularly IL-10 is a very known anti-inflammatory cytokine. But in a disease process, or in an individual who is genetically prone for a particular arthritis, or a patient who has developed an arthritis or is going to develop, the balance changes. The pro-inflammatory cytokines are produced in a huge quantity, and that is not balanced with an anti-inflammatory cytokines. Though all these mechanisms are biologically present in our system to protect us from viruses, from cancer cells. In the case of the diseased person, the pro-inflammatory cytokines are produced in a huge quantity, and ultimately what is meant to protect us actually causes damage to the joint. Hence, the modern treatment or the pharmaceutical industry is targeting these products so that if we try to prevent or block these pro-inflammatory cytokines, we can prevent activation of synovial sites, we can prevent activation of vascular adhesion molecules, we can prevent B-cell stimulation, thereby we can prevent degrading enzymes at the joint, metalloproteases, we can prevent cells homing into a joint resulting in joint damage, we can prevent immunoglobulin formation even at the joint level, thereby bring about a remission in this disease process. Next slide. And just don't get flabbergasted by this slide. This is only to show you, though at present we are having drugs which are targeting TNF-alpha, interleukin-1 and the B cells which are available in India today. There are so many other targets in which work is going on, and these drugs are there in phase 1 or phase 2 trials. And these are the various targets. The cytokine targets are the TNF-alpha, interleukin-1, interleukin-6. And the B cell targets are there against molecules called CD20, which is present on the cell surface of a B cell. And there's one more drug called the B lymphocyte stimulator, which is also against the B cells. Then you target the T cells on these co-stimulatory molecules on T cells. can target the osteoclast, again with drugs. There's one more thing called as the receptor-activated nuclear factor kappa ligand, which is also useful in preventing osteoclastic activity. One another target is called as the small molecules or the protein kinase inhibitors. Like that, several targets are there and against which various drugs are available, and they are at different stages of development and trial. Next slide. So I will just tell you a few points on the drugs that are available to us in the market in the Indian scenario. The first drug which came here was etanercept, and then this drug called infliximab. A few points on infliximab, which is a monoclonal antibody. Actually, it is made partly human and partly from the mouse origin. And in the case of rheumatoid arthritis, it is given as a 3 milligram per kg body weight infusion. In the case of spondyloarthropathy, you just heard from Professor Amita Agarwal, the 5 milligram per kg body weight. It is given at initially as a loading dose on the week 0, second week, 6th week, and thereafter once in 2 months, that is 8 weeks. This drug has been found to be very effective along with methotrexate when used than used alone. It's a very useful drug, and it has been proved by various trials to be very effective in the management of rheumatoid arthritis, particularly those who have not responded to the conventional disease-modifying drugs or their combination, like methotrexate plus leflunomide or sulfasalazine with methotrexate or hydroxychloroquine, this combination, or has failed. This drug has been found to be effective. Again, I will show in the subsequent slides about this particular drug. Of course, the side effects, whenever you play with or tamper with the immune system, you are bound to face certain problems, like try to bring an immunosuppression or try to bring the resistance level by these drugs. Naturally, infection is very common. A country like India, tuberculosis is very common. So when you give this, before giving these drugs, one has to screen these patients for any past history of tuberculosis, and they can trigger autoimmune things, like autoantibodies can form, because I told this drug is partly made from mouse autoantibodies, and it has got partly human portion. So they can trigger SLE-like status, autoantibody, malignancy, because TNF-alpha, I told you, is mainly meant in the system to prevent formation of cancer cells or malignant cells. So you try to suppress them, malignant cells can easily pass off and can survive in the system. So these are some of the problems in using biologicals. These are common to most of the biologicals about which I'm going to talk, so I may not again and again repeat the same things. So these are the common problems with all the biological agents. Infection, immunity, autoimmunity can be brought in, and malignancy are very common. Next slide, please. This is a structural diagram of infliximab, where you have the human component, whereas the variable region is from the murine etiology. So further research was done, and now they have got a fully humanized monoclonal antibody called adalimumab. The advantage is, if you remove this murine component and bring the fully human, then you don't develop, the patient doesn't develop autoantibodies against these monoclonal antibodies, thereby preventing less autoimmune problem or less lupus-like state in the patient. And this monoclonal antibody binds to the TNF-alpha, which is both in the soluble form as well as in the bound form. TNF-alpha, when secreted by the antigen-presenting cells, can interact with TNF receptors which are present on cell surface and induce inflammation. At the same time, there is plenty of TNF-alpha which is available outside the cell also, which is called the soluble form. And this advantage of infliximab is it binds to both the soluble form as well as those TNF which is bound already to receptors, thereby prevent the TNF activating the cell. Next slide. This is again a pictorial representation, like how this is the drug. It scavenges the TNF which is in the soluble form as well as this TNF which is bound to TNF receptors on the target cell. Whereas there is another drug called etanercept, and that particular drug is useful only in removing the soluble form of TNF alpha and not on the receptor bound TNF. Next slide. This is again a video showing how that is the TNF alpha which can get attached to a TNF receptor, and the drug can get attached to the soluble form and prevent target cell activation. Next slide, please. This is on etanercept. This is a fusion protein. Instead of a monoclonal antibody, they have synthesized a receptor like TNF receptor like protein. So what happens, it is a bogus receptor for TNF. So the TNF doesn't know whether it is a real TNF receptor or a false one. So it can get attached to that, thereby it is removed from the soluble TNF which is available, which is not yet attached to the cell, will be scavenged by this fusion protein. The advantage of this drug is it is given as an insulin-like injection, can be given as an OP procedure, and it is very useful in children. It has been widely used in juvenile rheumatoid arthritis, been found to be very effective, and that is the advantage of etanercept. And again, it can have the same sepsis, pancytopenia, autoimmune problems. These are the problems that can occur with etanercept also. Next slide. And as I said, we should not, when we use these biological agents, we should be wide awake. We should not close our eyes and be happy, because even sometimes after a single infection, people can develop pneumonitis or tuberculosis. So you have to be agile in using these drugs. Next slide. I'll just quickly go through a few other molecules that are available and give you a bird's eye view about that. This is the fully humanized monoclonal antibody called adalimumab, and it also blocks TNF alpha. It is given as a subcutaneous injection of 40 milligram once in 15 days, every other week, and can be combined with methotrexate, very effective in rheumatoid arthritis as well as in ankylosing spondylitis. Next slide. This is a drug called anakinra. The RA stands for the rheumatoid, or it's an interleukin-1 receptor antagonist. INRA is interleukin-1 receptor antagonist. I told you, apart from TNF alpha, interleukin-1 also plays a major role in inflammation. So if we have an agent to prevent interleukin-1, then there also we can bring about a remission in rheumatoid arthritis. That was the idea. So just like etanercept, they made a receptor protein for the interleukin-1. So what happens, interleukin-1 gets attached to this drug, and thereby the interleukin-1 is removed from that site. So it competitively binds interleukin-1 and blocks interleukin-1 cell signaling. It is given as a subcutaneous injection, 100 milligram daily. Next slide. A pictorial representation how interleukin needs to be attached to a receptor, and you bring in anakinra here that will remove the interleukin-1, thereby prevents signaling by blocking interleukin-1. Next slide. The disadvantage with anakinra is it has not been found to be effective in rheumatoid arthritis, but it has been found to be very useful in a condition called Still's disease, where a patient can have severe fever-like pain. The rheumatoid factor can be negative, ANA can be negative with minimal joint pain, but they keep on having high temperature every day. Within 24 hours it will go and come down, and with rashes. So it's been found to be very effective in a condition called Still's disease. So from the cytokines, interleukin-1 and TNF-alpha, we'll move on to B-cell, the B-cell therapy. This particular drug is available in India now. It has come to the market. It has actually opened a new vista in the treatment of rheumatoid arthritis, because all these days we were under the impression that T cells were the main culprit in rheumatoid arthritis. So everybody was focusing on T cells and their relationship with other cells, coolly forgetting that rheumatoid factor is the main test that we do for rheumatoid arthritis. And all these days we were thinking that rheumatoid factor was a byproduct of T cell activity. Now the focus is shifting on B cells, whether B cells themselves can induce rheumatoid arthritis, and the production of rheumatoid factor itself can cause a damage and a poor prognosis to the disease condition. So what is the role of B cells in RA? It can also present antigen to T cells, and so can cause a direct T cell activation. And as you know, rheumatoid factor may play a major role, as well as cytokine production. Like pro-inflammatory cytokine can be produced by B cells. So suppose you knock off these B cells or put them into inaction, probably you can bring about a remission in rheumatoid arthritis. How is it? Next slide. This is only to show how B cells can interact and then produce cytokines or pro-inflammatory cytokines, resulting in an inflammation or joint damage in rheumatoid. Next slide. So they brought a drug called rituximab, which is again a monoclonal antibody, partly mouse and partly human. And it is against a molecule called CD20, which is present in pre-B cells as well as in mature B cells, and not on plasma cells. So it is highly specific for only a particular level of B cells, so that you don't tamper with the immune system. And this is given again as an infusion on day 1 and day 15. And this is against that CD20 molecule. But though this slide was prepared a little earlier, that when rituximab was not available, we don't find this amount of serious infections when compared with the other biological agents, and it is very useful in rheumatoid factor positive, that is seropositive rheumatoid arthritis, and not in seronegative rheumatoid arthritis. The future is it may be useful in lupus, where there is a lot of autoantibody formation occurs. So rituximab has been found to be very effective. The only thing is, when you give this drug, the immunoglobulin levels can come down, but it is maintained at a very low level, and the B cells also, the white cell count also may come down. In general, has been found to be a very safe drug, though it is very expensive as of now. Next slide. This is the CD20 molecule, and that is the drug which gets attached to the CD20 molecule, thereby bringing about a lysis of the B cell, and it is and prevents rheumatoid factor formation. Next slide. And likewise, I showed you about other targets, cellular targets. It's a drug called the beta-cept against the T cell co-stimulatory molecule CD80 and 86. This drug is also being brought in for rheumatoid arthritis, and against drugs called against protein kinases. These are some of the drugs which are now in the trials now. Next slide, just for information's sake. From here, I'll just quickly go through the different rheumatological conditions and what is the level of biological agents in these conditions. You had a brief information about the biological agents in spondyloarthropathies. This is a case of ankylosing spondylitis, and this patient had ulcerative colitis with axial skeletal involvement, uveitis, bamboo spine, and that is DIP arthritis with nail pitting, psoriatic arthritis. In all these conditions, biologicals are going to be the answer. I may differ from Dr. Amita Agarwal as far as the treatment of spondyloarthropathy. You can refer these rheumatic clinics of North America, rheumatic disease clinics of North America 2006. There's a complete article on all this, the newer modalities of treatment. There in spondyloarthropathy there is a separate chapter. There they have quoted number of references where exercises, NSAIDs, methotrexate, sulfasalazine, all are not very effective in controlling the disease. Though as of now, until now, we have only these. We straight away say go for swimming, do exercise, everything. But I have a patient with ankylosing spondylitis who is a national champion of volleyball. Everything is fixed. These people, I feel only biological agents are going to be the answer until we find the cause, etiology and drugs for preventing those which are inciting the disease. Until then, only biological agents are going to give a respite for these patients. Of course, the cost, the other problems like infection has to be kept in mind. So it's better to start biological agents in spondyloarthropathy at a much earlier stage rather than when a patient comes to you with ankylosed spine or in the neck or a gone case of hip joint. Because as you replace a hip also, then the question comes whether we can give biological agents for these patients, whether this patient will develop septic arthritis in a prosthetic joint. All these problems will start. So at the early stage, try to work out for getting biological agents somehow or other. And I find those people who are in the software field who are making a lot of money if they develop ankylosing spondylitis. Some of my patients are able to buy these drugs. I told them at least yearn for that to counter your disease, to cope up. Next slide, please. So what is that? But the main drug, these are the drugs that are available. But infliximab and where is that? Okay. These are the drugs that are being used, being on trials. Next slide, please. But I will show you the other slide. Next slide. Like infliximab and adalimumab have been found to be very effective in the treatment of psoriatic arthritis as well as spondyloarthropathies. Etanercept also is okay, but these two drugs are quite effective. And they are now working on two other things like this alifacept and ifalizumab, but they are very highly hepatotoxic. So in psoriatic arthritis, etanercept, infliximab and adalimumab are very effective. But infliximab I have personally used and I find it to be very effective in both skin lesions as well as for arthritic conditions. Next slide. And in the treatment of uveitis, this is also a big problem. They found that infliximab is somewhat effective in bringing about remission in anterior uveitis. Next slide. And lupus. It's again a big problem. We have been using cyclophosphamide right and left because now mycophenolate is coming in a big way. What is the role of biological agents? Next slide. That is SLE, SCLE and DLE. Biological agents are useful in very severe resistant lupus manifestations. Particularly drug rituximab is very effective because it's again targeting the B cell. There are other agents, but this particular drug is useful and it definitely is useful in renal lupus, lupus nephritis. Next slide. Antiphospholipid antibody syndrome, Professor Chandrasekhar's favorite topic. Again, a lot of work is going on and probably I think rituximab may play a major role, but we are awaiting studies. Next slide. polymyositis, particularly dermatomyositis, they found, because in dermatomyositis again B cell activity is more. So TNF-alpha blockade as well as B cell depletion by rituximab will play a major role in controlling resistant cases, because as of now we are only treating them with steroids and methotrexate. So biologicals are indicated in, particularly in dermatomyositis. Next slide. Vasculitis, again, very difficult to treat. Nowadays, we are using only these steroids, cyclophosphamide, and maintenance with azathioprine. So biologicals, they have tried the following drugs, but rituximab may play that is a case of Wegener's granulomatosis. This is again to reiterate that Kawasaki infliximab, whereas in Wegener's infliximab and rituximab may play a role, etanercept is not in favor. And of course, rheumatoid vasculitis, TNF-alpha blockers are the ideal agents. Next slide. So, to sum up, so biological agents are mainly based on the basic principle of cell-to-cell interaction, which incite an immunoinflammatory event. Thereby you block them, resulting in remission in the disease. What are the problems? One is cost factor. It's beyond the reach. Of course, in the days to come, it might change, because just like air travel, once upon a time, we couldn't even think of air travel. Now it looks less than the AC two-tier cost. Likewise, more agents come, more companies come into play, or Indian companies start manufacturing them, definitely the cost factor will come down. But the main points to be answered will be infection, autoimmunity, development of autoimmunity, and malignancy. These will be the problems, but again, different molecules at different disease entities might give us an extra hand to counter these disorders. Thank you.
Professor Krishnamurthy, for giving us a nice talk about the biological therapy. These agents are probably the first very specific agents against specific chemicals or mediators like cells, B and T cells, and they are going to be the future therapy. It's not in widespread use right now because, as you know, it's the cost factor. But these are going to be the agents to look forward to during the next 10 to 15 years, and if the cost comes down, it's a blessing to us. With this, we come to the end of the first three lectures, first sessions, and we are going for a coffee break. And after the inauguration and the questions, you can ask Dr. Krishnamurthy during the break.
The memento to Dr. V. Krishnamurthy. Then to hand over the memento